Hello, everyone, and welcome to the LINCS webinar. I'm Lindsay Joseph, the LINCS Program Officer with Resolve to Save Lives. LINCS is a growing online community and resource sharing platform for people working to improve cardiovascular health around the world. LINCS was developed in collaboration between Resolve to Save Lives, the World Health Organization, and the U.S. Centers for Disease Control and Prevention. Before we begin, I'd like to review a few housekeeping rules. The lecture will be about 30 minutes long, followed by a Q&A session. Participants will be muted for the duration of the session, but will have an opportunity to type in questions using the Q&A button located at the bottom of your screen. The webinar is being recorded and will be posted to the LINCS website after the session. I will now hand it over to Dr. Andrew Moran, Director of Global Hypertension Control Program at Resolve to Save Lives, to introduce today's speaker and topic.
Okay, good day, everybody. I'm Andrew Moran from Resolve to Save Lives, and today's webinar is about a really important topic. It's the environmental determinants of hypertension. We all know that globally hypertension kills approximately 10 million people each year, and that's more than all infectious diseases combined. Resolve to Save Lives works with global, national, and local partners to help establish and scale up proven strategies to improve control of high blood pressure. And while known causes of high blood pressure, such as high sodium intake and low potassium intake, obesity, sedentariness, and harmful use of alcohol have been well studied, the role of environmental factors, such as air pollution and heavy metals, has come to attention only recently. But it's important to note that when we look at the global burden of disease study, that air pollution ranks among the leading risk factors for cardiovascular disease, and is important as high blood pressure and nutritional factors and tobacco smoking. So this lecture will discuss the role of air pollution in increasing blood pressure at the population level and the mechanisms underlying that increase. So before we start, I just want to take a moment to introduce the speaker, Dr. Prabhakaran. He's a cardiologist and an epidemiologist by training. He's an internationally renowned researcher and currently the Vice President of Research and Policy at the Public Health Foundation of India, the Executive Director of the Center for Chronic Disease Control based in New Delhi, India. And he's a professor on faculty at the London School of Hygiene and Tropical Medicine, the chair of the Science Committee at the World Heart Federation, which is actually the reason he's coming to speak to us today. And he leads the India GeoHealth Network, funded by NIH, the US NIH, that aims to study the relationship of air pollution and cardiovascular outcomes. And I've known Dr. Prabhakaran for a number of years, and it's been really amazing to watch his career, which is really quite exemplary and really a great example of someone who works really at the nexus of clinical cardiology and clinical medicine and public health, and really brings the strength of both of those disciplines. So without further ado, I hand it over to you, Dr. Prabhakaran. We're really excited for your talk.
So thank you, Andrew. A very good morning, good afternoon, or good evening to everyone, wherever you are. Thank you for joining this webinar. It's indeed a privilege to give this talk. So let me take a moment and share my screen, and without much ado, kick off the talk. So as Andrew pointed out, I'm going to talk on the environmental determinants of hypertension or high blood pressure. And the reason for that is this is emerging as a major problem across the world, but it's under-recognized both by the medical profession as well as the lay community, and as well as people who are interested in the area of hypertension. Before I do that, let me briefly outline as to what I'm going to speak. I'll introduce give a brief introduction on hypertension worldwide, look at some of the currently understood causes and solutions, which has already been alluded by Andrew, look at some of the environmental determinants, such as air pollution, using air pollution as an exemplar, and what can be done about this, and provide some simple solutions in terms of mitigating the problem of air pollution in the world. So if you look at high blood pressure, particularly from the global burden of disease study, it says in the year 2017, there were almost 10.4 million deaths, which accounts to something like 136 deaths per 100,000 population. It contributes to almost 18% of the total deaths. And in terms of years of lives lived with disability, it contributes to almost 22 million. And in terms of disability adjusted life years, which is a metric which measures both premature death as well as the number of years lived with disability, it comes to a huge whopping number of 218 million. This is almost like close to 9% of the total dailies. But one point that I want to make, which is very important for us, is that there is a high burden of hypertension among the LMICs, particularly in several parts of Africa, Latin America, Southeast Asia, and South Asia. In fact, there's a decline in blood pressure in European and North American countries to the tune of average decline of around 2 millimeters, which is a very big decline as far as the population is concerned. We carry out an awareness program called the MAME Measurement Month, which has been happening since the year 2017. So far, nearly 5 million people have been screened across the world. Now, close to 5 million. Now, what this shows is that the burden of hypertension is huge. Of course, this is an opportunistic screening, and you may say that it's not very accurate because these are people who are interested in getting the blood pressure screen. But what I would say, it very closely resonates with what the actual prevalence is. It shows that the prevalence of hypertension worldwide is close to a third of the population. But the important point I want to make is only around slightly more than half the population are aware that they had blood pressure, and nearly a third had never checked their blood pressure ever in their life. And these are adult populations. And only half of them are taking medications, and nearly half of them are under control, which is what we would expect in terms of hypertension. Now, coming to what is well known about hypertension in the world, it can be considered as a disease of three paradoxes. First, it's very easy to detect, but the diagnostic rates are dismal. All you require is a sphygmomanometer or some form of blood pressure measuring equipment, which is ubiquitous, but even then the detection rate is quite dismal. It's easy to treat, but treatment rates are quite disappointing in several parts of the world. Not more than a third of people get treatment, and even if you go to very interior rural areas of India, for example, only 10 to 15% of people will be getting treatment. There are several potent drugs that are available, but control rates are quite abysmal. But we know a lot about hypertension. Dr. Moran alluded to all of these, that is high sodium intake, low potassium intake as exemplified by low fruit and vegetable intake, harmful use of alcohol, overweight and obesity, and low physical activity. All of these are known to increase the risk for hypertension and high blood pressure. And we also know the potential solutions, which are again simple lifestyle changes. I mean, you increase the physical activity, have a balanced diet, increase the potassium intake to fruit and vegetable intake. If you have hypertension, take very simple drugs which are not expensive, and you can also have some kind of non-personal policy level intervention, as what happened in the United Kingdom, where they reduced sodium in bread over a 10-year period, and there was a substantial decline in blood pressure over those 30-40 years range. So these are some of the simple things that can be done. But when we ask people, how do we change the lifestyle of people, they always say that, okay, we need to provide education, we need to create awareness. And let's see what happens with this. So in terms of health promotion, we require to really do three things. We require to provide knowledge to people so that they say, I know. We need to motivate them so that they say, I want. And we need to provide the skills that are necessary for them to act so that they say, I can. And ultimately they act to perform personally and as well as reach and teach others. Now, for all this, as you can see, we require an enabling environment. And that enabling environment is extremely important in terms of control of any of the cardiovascular risk factors. But unfortunately, in terms of health promotion, we have far too long focused on the I know component and have ignored the other three, and particularly the enabling environment. So, shifting focus a little bit, let me come to the point about what is not so well known. What is not so well known are the upstream determinants, the so-called environmental determinants. That's air pollution, noise pollution, the lack or presence of green spaces, water pollutions, particularly heavy metals in water, and others. Now the question is there evidence to this? So model data suggests that in terms of global cardiovascular deaths attributable to air pollution is one of the leading causes of global cardiovascular deaths, and it's one amongst the top 10 causes with high blood sugar, high body mass index, high diet and sodium, so on and so forth. And it's been estimated that air pollution and lead, actually, which is a heavy metal, it's accounted for an estimated 10% of all deaths and 17% of cardiovascular deaths. And exposure to lead remains a serious threat to the population health. And it's estimated that as much as 18% or close to 400,000 deaths per year in the United States could be attributed to environmental lead exposure. My focus today is going to be on air pollution. I'm not going to talk about water pollution and heavy metals because that would take away a lot of time, and I'll just focus on air pollution henceforth. Now, air pollution doesn't occur alone. There is an interaction between air pollution, built environment, and green spaces, and I'm going to show with some examples from India. As Sir Jeffrey Rose said, that sick individuals arise from sick populations, and sick populations are closely related to the environment in which we live. So the question is, how did we study this? We can study this both cross-sectionally and longitudinally. The world literature is populated with a lot of cross-sectional literature, but it's important that for credible credible associations, we need to look at longitudinal studies. So first we established a study called CARS, which is Center for Cardiometabolic Risk Reduction in South Asia Cohort, which was funded by the NHLBI, and this is being done in collaboration with Emory University, All India Institute of Medical Sciences in India, and Dr. Mohan's Diabetes Research Center in Chennai, along with the Public Health Foundation of India and my own Center for Chronic Disease Control. So this is a population-based sample of close to 20,000 adults who have been followed up for up to 8 years. And we used a design which would provide us with a representative population of 2 megacities in India, one in the north, that is Delhi, and one in the south, which is Chennai. It's a carefully phenotyped and geocoded study population, and we have close to 360,000 aliquots of sera, plasma, Buffy-coat, and urine. And we have every annual follow-up. Every alternate year, we collect blood samples so that we can get incidence of diabetes and lipids and others. But we also do measure blood pressure in person every alternate year. And every year, we get data on hospital admissions and mortality. We were also funded by NIH again on the GeoHealth Program, which is a prestigious program of, there are 7 GeoHealth centers across the world, and we are one of the GeoHealth centers. The idea here is to have a fully integrated research and training program on air pollution and cardiometabolic diseases with policy relevance to improve health of Indians and a hub for the South Asia region. The objectives are listed here. The most important objective was to make exposure assessment robust, so develop a model to estimate ambient air exposure to air pollution in Chennai and Delhi, to estimate the association between exposure of air pollution, temperature, cardiometabolic risk factors and diseases and built environment, to examine DNA methylation patterns associated with air pollution biomarkers, and examine the association between air pollution and vitamin D levels. I'm going to talk about the first 2 objectives. So the main objective obviously was to link PM 2.5 levels, which PM is particulate matter 2.5, which is a measure of air pollution, to incident cardiovascular disease risk factors and outcomes in Delhi and Chennai. The first was to develop an exposure model to predict PM 2.5 concentrations in a smaller area. Most of the PM 2.5 measurements across the world is in a larger area of 10 square kilometer to 10 square kilometer. Some in the United States have published data on 1 square kilometer spatial resolution. and in collaboration with Harvard, that's what we're trying to estimate. So the city of Delhi was divided into a total of 1,635 grids, and we had data for all the days from 2010 to 2016 that spans close to 2,500 days, and there were close to 4.18 million observations, and it covered an area of 1,484 square kilometer. We measured air pollution from several sources. There were monitoring stations which gave us data. There are 25 monitoring stations in Delhi which measure both PM 2.5 and PM 10, and we also model the PM 2.5 levels based on PM 10 levels from the monitors that were measuring PM 10. We use satellite data to obtain what is called as aerosol optical depth, which indirectly gives you the value of PM 2.5, and we adjusted for several parameters such as the vegetation, such as ultraviolet emissions and active fires. We used emission inventories which are established close to industries, and particularly this accounts for brick kilns which are dotted around the city of Delhi and other polluting industries. We adjusted for several meteorological variables that included temperature, humidity, wind speed, precipitation, rain, so on and so forth, and also looked at land use, because land use makes a big influence on PM 2.5 levels. That included the length of roads and runways, location of bus stops, the last mile connectivity for metro connections, and population density. Using all this, we used a machine learning technique called ensemble modeling and artificial intelligence to obtain the PM 2.5 levels in the city of Delhi. So this is how it looked. As you can see, starting from 2010 onwards, you can see the red spots constantly increasing over. By 2016, even by the month of September, October, we had huge spot of red, which means the levels of PM 2.5 was pretty high by 2016. Now, why till 2016, 2017 is because we had cohort data till 2016, 2017. We extended this analysis further, and we will look at future incidents of various other cardiovascular risk factors as well as cardiovascular death. So to summarize, what happens here is there were 3,296 individuals from close to 2,200 households with 3 measurements of blood pressure over 7 years. So what we found was for every 25 microgram per cubic meter of PM 2.5 increase, the blood pressure was higher by 3.5 to 5 millimeters, but this depended on the body mass index. So the question here is, if we can decrease the annual PM 2.5 by 25 microgram per cubic meter, we can potentially decrease systolic blood pressure by 3 millimeters. Now you may ask this question, how does this 3 or 4 millimeters make a difference? At the population level, it makes a huge difference. Currently, the annual average of PM 2.5 in Delhi is close to 100. Now suppose we decrease this by, it's close to 125. We decrease it by 25 and bring down the PM 2.5 levels to 100. We would decrease the prevalent hypertension by 5%. If we get it to the current Indian national standard, which is supposed to be at 40, which means that we have to decrease PM 2.5 by 85, our prevalence of hypertension would decrease by 15. I want to just put this in the context of New York or San Francisco or any other city, where the PM 2.5 levels on an average per year is somewhere between 8 to 15. It's as low as that, and you can see it's almost 10-fold higher in the city of Delhi. Now these are some graphs which show that the relationship between short and long-term exposure, be it a 1-day exposure, 7-day exposure, 3 months exposure, it is quite consistent that the systolic blood pressure shows a relationship. But in terms of the diastolic blood pressure relationship, it is not so accurate, but it also shows that at least in the short term, there is a relationship with a higher diastolic blood pressure. So this slide shows the interaction of body mass index and waist hip ratio. Again, shows that the blood pressure increase in blood pressure may be operating through higher BMI or higher central adiposity. And we are looking at this in terms of pathways for hypertension as to how air pollution contributes to hypertension through BMI. Then moving forward, there's another area of concern is noise pollution. You can see the bigger dots here The bigger dots here denotes higher blood pressure. The smaller dots mean the blood pressure is lower. And you can see wherever the traffic density is very high, there is a higher systolic blood pressure. And where the traffic density is lower, the blood pressures are lower. And this is after adjustment for socioeconomic variables, because one might argue that people who are living in this area may belong to a different socioeconomic class. The second thing I wanted to show here is these are the cohort clusters which have higher blood pressure than the cohort mean of Delhi. Now, this is the same area where there is low physical activity. This is the area where there is a low physical activity. And when we looked at green spaces, we looked at several parameters and related it to blood pressure. And as you can see, green spaces emerge as an important factor. The low amount of green spaces increases the risk of hypertension by around 12% or so. So clearly identifying some of the important environmental determinants of blood pressure. The next point that I want to make is all of us know that physical activity is extremely important. Physical activity is an important parameter which determines blood pressure and body weight. And for people to be physically active, we require what is called as good walkability. And we looked at walkability index of Delhi and its challenges to physical activity. And we used several parameters that included vehicular congestion, that included comfort of walking, whether footpaths or sidewalks are available, whether a lot of vehicles are parked on the sidewalks, the safety index of walking, the exposure index to ultraviolet as well as to air pollution, the connectivity index, and it calculated the walkability in Delhi. The red areas indicate poor walkability. Look at the green areas, which is in the heart of central Delhi, which houses many of the offices and other places, the New Delhi area, but all of the other areas, it's not adequately walkable. So this has important information in terms of urban planning as to what needs to be done. So if I had to summarize the relationship of ambient air pollution and hypertension, there is long and short-term exposure to elevated particulate matter concentration is associated with increased blood pressure and risk of developing hypertension in urban India. Interquartile range increases in annual and monthly average exposure to PM2.5 were associated with around 2 millimeter increase and 3 millimeter increase in systolic blood pressure respectively. Similarly, an interquartile range increase in 1 year and 1.5 year, the average exposure increased the risk of developing hypertension by around 50%. And these associations are modified by markers of obesity, such as waist-hip ratio or BMI, with stronger associations in obese populations. So now the question is, what are the unanswered questions in terms of air pollution? Now, particulate matter 2.5 is not a single entity. There are multiple substances in this PM2.5, nitric oxide, sulfur dioxide. There are several others, metals and so on, black carbon. So we need to estimate which one is the cause so that we can identify which factor. Is it vehicular pollution which is causing this? Is it the construction activities that causes the increase in PM2.5? Or are there other factors? So we need to look at that. Then the second is, how does indoor air pollution interact with ambient air pollution? So to do this, we are looking at personal monitoring of individuals where we have given them an accelerometer, a PM2.5 monitor and a GPS machine so that we can develop their PM2.5 exposure profiles, investigate source-wise contribution in personal exposure, quantify transported ambient air component in indoor PM2.5 levels, and describe levels and patterns of personal crustal and toxic metal exposures. So this is ongoing. We would get the results in the next few months or so. But just wanted to show one case study of a husband and wife who reside in a slum in East Delhi. Due to poor ventilation conditions and indoor air pollution, the lady who is a homemaker has higher exposures than her spouse. You can see this husband is a rickshaw driver, but despite being exposed to high degree of ambient air pollution, the pollution exposure to the women is considerably much higher. The next point that I wanted to make is we need to increase potassium intake, and we have advocated fruit and vegetable intake in the environment. What are the complexities that are involved in food systems? These are data from a meta-analysis that has been conducted, which shows that fruits that are grown, first of all, fruits which are grown in water depleted areas, in many parts of India water depleted, the growth of fruits is adversely affected, it decreases. But more importantly, the amount of beta carotene in these fruits is somewhat lower. So I think one needs to take this into account. And also when we say increase fruit and vegetable intake, you can see the complexity that is involved for the poor availability. They're perishable, we require transport facilities. Nearly 50% of the fruits and vegetables are lost during transport in India. Then we require, there are international policies which makes import of fruits, and therefore the local fruits are not grown. In fact, we get fruit, apples all around, but some of the local berries may not be available. So these are some of the issues that we need to look at when we, at a system level, in terms of fruit and vegetable intake. The last thing which I want to point out is that we are living in an interlinked world. So industrial scale livestock breeding leads to obesity, cardiovascular disease, and cancer. Also leads to grain diversion and food crisis. There's climate change with increased methane and deforestation, and we are also seeing pandemics. So global meat production will double from 229 million tons in 2009 to 465 million tons in 2050. It's estimated that if everybody in the world becomes vegetarian at least for one day in a week, we can achieve the reduce global warming and reduce the global temperature by around 1 degree centigrade. So that's the power of looking at upstream determinants. What can the health system do? What can the medical profession do in terms of combating air pollution? Health sector plays a key role both as a contributor and mitigator of environmental health. So we are working in the area of strengthening capacity for research, communication, and advocacy in air pollutions. There's some preliminary evidence that greening of hospitals can improve health outcomes. So in order to do this, we have specific aims in terms of health sector engagement and capacity building, air pollution monitoring policy and advocacy, improving the knowledge, attitude, and practice of health practitioners towards health effects of air pollution in Indian cities. And we're also trying to create a roadmap to achieving the national ambient air quality standards in India. So the first thing that we have done is we have created a platform called the Health and Environment Leadership Platform, which has over 7,300 healthcare institutions in India. We're also trying to do hospital-based air pollution monitoring because there are 122 cities in India which do not have any estimate of air pollution because there are no monitoring stations. So along with providing education to healthcare providers, we can also use this as monitoring stations to estimate air pollution in each of these cities. The next is we're looking at the doctors' attitudes to increase awareness. In fact, this is going to be published soon. The idea is to look at the knowledge and awareness of doctors about health impacts of air pollution. In fact, in our in-depth interviews with many of the doctors who included cardiologists and pulmonologists, they were not aware that one of the important risk factors of air pollution is cardiovascular disease. In addition, this will also create climate smart and climate resilient hospitals. So I've showed a kind of a wide sweep of what can be done in terms of upstream determinants, particularly in relation to air pollution. So I think when we approach research for hypertension, we need to look at it from multiple angles. All the work that we have done so far is in amassing scientific credibility in terms of biomedical and epidemiological research. We need to look at other areas, particularly the health systems research, involve the health systems in terms of combating air pollution, and also in terms of creating that awareness, we require social sciences research. And therefore, I would say that we need to work together. All the disciplines need to come together and work in a transdisciplinary fashion. So when we have to combat an illness such as hypertension, we require multidisciplinarity, we require disruptive innovations, and we need to pay attention to policy and upstream determinants. So I will end my talk with these two quotes. We have done a lot of work, but I think there's still a lot more that needs to be done. The enormity actually stares at our face, but at the same time, we need to be optimistic. As the Persian philosopher of the 10th century said, there are no incurable diseases, it's only a lack of will. Thank you.
Thank you, Dr. Prabhakaran, for that excellent presentation and very informative. We will now open it up for the Q&A session. Again, participants will be muted, but we'll have the opportunity to type in questions using the Q&A button located at the bottom of your screen. We'll give everyone just a few seconds to start typing in their questions. But to start, I had a question about the risk factors of indoor pollution, air pollution, and given the current situation where many of us are still in areas where we are under lockdown restrictions due to the coronavirus pandemic, I wonder what recommendations you have for mitigating the risk of exposure to indoor pollutants given our movement restrictions.
So, I actually didn't think of that angle, is because what has happened in India, particularly with the lockdown, the pollution levels have improved. I've been able to see the clear blue sky in the last 2 months, which I've never done in the last so many months. So clearly air pollution has come down because of lockdown, so that's a boon. Now, indoor air pollution is related to two factors. In the urban locations, indoor air pollution is higher basically because if you're living close to a major road, then the chances of indoor air pollution is high. Second is the use of fossil fuels for cooking. In the cities, it is there in the slums, but it's not as widespread as in the rural populations. Now, one of the policy programs of the government of India is to provide cooking gas supply to these houses, and that might improve. So we have not really looked at that policy change and evaluated it, but I was just giving a very extreme case study of where indoor air pollution was extremely high, but in the COVID lockdown situation, I think it may be better, given that the ambient air pollution levels have come down.
Great, thank you. First question in the Q&A chat, how does air pollution pair up with smoking, particularly with regards to advocacy?
So another reason for indoor air pollution is smoking. Actually, I forgot to mention that. That is, smoking is an important reason for indoor air pollution. So we need to tease that out, and our personal monitoring study will help in kind of teasing out how much is the contribution due to secondary smoking and due to use of fossil fuels and ambient air pollution. So we need to look at that problem. But also there is an interaction between smoking and air pollution. Smoking damages the lungs, and smoking increases the cardiovascular disease, and air pollution also does. So there is an additive interaction there. And clearly people should stop smoking, and also we should take care of the air pollution issue.
Thank you. Next, we have a question. Have you done studies in rural areas where air pollution may be lower? And if so, what is the hypertension relationship there?
We have not really studied the data, looked at air pollution in rural areas. We are developing this model. Development takes a lot of time. It actually requires a supercomputer to develop the model. We are working on an all India model, and so we'll be measuring rural air pollution. But prima facie, it appears that air pollution is lower in rural areas, clearly because of the lower density of population, the lower transport issues, lower levels of construction activities, and higher open spaces and green spaces. The air pollution levels are lower. Second, there is a lower level of hypertension and high blood pressure, and all the cardiovascular risk factor. In fact, in India, it's almost in the ratio of 2:1. But in many parts of South India, the rural areas are almost becoming similar to urban areas. But in major parts of India, hypertension prevalence is lower in rural areas. So once we have the model, we'll do the study.
Thank you. Next up, are there any citywide initiatives in Delhi aimed at reducing air pollution?
So over the last 2 or 3 years, there have been a lot of approaches in terms of reducing air pollution. In terms of policy, for example, all the public transport vehicles, the taxis and the tuk-tuk or the auto rickshaws that we have had to run on compressed natural gas, which is a clean fuel. So that's one thing that was done. Around 20 years back, the Supreme Court ordered shifting of all the polluting industries to outside the city. The third, they attempted an odd-even policy, which did not really change much, so it still continues. Diesel prices are going up. Diesel is one of the unclean fuels, so that's another area of work, diesel prices have come closer to petrol, so it's becoming unviable to buy diesel vehicles. The third is, the fourth is Delhi is moving towards the Euro 6 norms, which is a for vehicle manufacturing. So which means that we'll have cleaner vehicles. The hybrid vehicles and vehicles run on electricity are not yet available in India, so that might come much later. Then, in terms of construction activities, there have been some guidelines on construction to reduce construction dust. Its implementation needs to be looked into. So then, during times of high levels of pollution, there are certain local issues such as burning of crops in and around Delhi. So the Supreme Court has provided some guidelines on mitigating that, and in terms of using firecrackers and so on. There are been some policy changes, but it may take a few more years for it to be completely implemented.
Certainly. The next question is circling back to our coronavirus discussion. What would you believe will happen during or after the pandemic, since people with NCDs are experiencing the lack or shortage of access to medications or the ability to exercise? How would health systems and governments prepare for the consequences of this period?
I think most of the governments worldwide are grappling with the pandemic, and therefore there's been some neglect of non-communicable diseases. The WHO did a survey in the end of March and found that nearly 30% or nearly a third of NCD services have been curtailed all over the world. They did the study in 155 countries. India was one of them. So services of NCDs were curtailed, screening programs have been curtailed, cardiac rehabilitation has been affected, and some of the wards, hospitals have been converted to COVID hospitals, so there are less number of beds. And more importantly, because of lockdowns, people have not been able to access health systems and get drugs. And so there have been multiple issues in terms of NCD care. To put, and I think one of the recommendations has been, as we move towards the second wave, if it comes, and as we move towards framing policies in terms of how we are going to handle COVID, I think NCDs have to come back into focus. We need policies on all these aspects. Just to give a perspective, there are 25,000 deaths in India every day. I mean, on average, there are totally 10 million deaths. And there are also, if you divide it into per day count, it is 25,000 deaths. And of these, nearly 16,000 deaths are related to non-communicable diseases. And in terms of total deaths that has happened because of COVID, it's around 12,000. So I think we need to keep that in perspective, and we need policies on NCDs.
Great, thank you. And just a note to participants on the webinar, we have a dedicated page on the LINCS website to COVID-19, and we've been trying to add resources about NCD management during this time and how hypertension programs can implement telemedicine and also restructure the primary healthcare setting in order to best treat patients with non-communicable diseases. We encourage you to look at those resources, and if you also have resources that you would like to see featured on the website, please send them to me directly. Next question, what is the risk of advanced age in relation to air pollution and high blood pressure?
So it is said that age is a risk factor for hypertension. That's essentially because of our lifestyle. In fact, studies that have been done in Africa where in Kenya, the African tribal population who lives in communities, when they migrated to the cities, within around 3 months, their blood pressure increased. And they also have looked at age-related increase in blood pressure, which was not observed in that population. It continued to remain flat. But the common teaching has been that age is an important risk factor for hypertension, and that's largely because of our lifestyle. And if we can control sodium intake, if you can increase our physical activity and increase our potassium intake, be moderate on alcohol, I think we will be able to stem that increase of blood pressure as age advances. Air pollution is much worse for individuals who are older because they have several comorbidities, particularly patients with heart failure can worsen because of air pollution. And we need trials like for example, using air purifiers or N95 masks to see whether outcomes are better in terms of 6-minute walk test or in terms of reducing mortality. We could look at such trials in the future. But I think clearly age, hypertension, and air pollution interact with each other.
Thank you. Question from Beatrice. What work is being done in Latin America and the Caribbean to address air pollution? Do you know if the studies that you are working on are also being replicated in other regions?
I'm not aware of work being done on air pollution in Latin America. There is one study which has been funded by NIH, and that's in Suriname. So they are looking at air pollution. I can't recall the details. So apart from Suriname, I'm not aware of other places.
Thank you. In the chat we have, has it been studied how much effect over urban air pollution is there from burnings that occur in nearby areas?
So that is seasonal, and it does happen particularly in the months of October and in the months of November and December. So there are multiple factors that are involved. Crop burning is an important factor because in northern India, particularly in Punjab and other regions, Punjab, Haryana, which are states which are close to Delhi, farmers actually have two cropping patterns. So when they change over from one crop to another crop, so they have to burn the crop residues. So I think, and using mechanized way of disposing them is expensive. But with the government actually putting in some money into the budget in terms of providing those mechanized ways of doing it, I hope it will come down in the future. In terms of brick kilns, yes, there should be some contribution to it, but again, it involves employment of several people, so we need to look at it carefully. But it's not a very huge contributor to air pollution in Delhi. It does contribute some, but not a huge contributor. Then there are spontaneous fires which happen, and that could contribute, but unlike California, for example, it doesn't happen very frequently in and around Delhi.
Thank you. The next question is, again, about the connection between the associations between air pollution and hypertension. And this person has asked, how did you know to associate air pollution with hypertension? Could the situation also be related to stress?
Stress has been attributed very frequently to hypertension and several cardiovascular diseases. Now, air pollution actually can increase stress, and it can operate because there's an association of increased heart rate to PM 2.5 levels, and heart rate increases with increased sympathetic activity, and therefore can indirectly lead to contribute to hypertension. While stress has been frequently attributed, empirical studies have not actually evaluated that very well. There are indirect evidences, like for example, there are small studies that show with yoga, blood pressure reduces, and yoga is supposed to alleviate stress. So, but here clearly we are showing it in relationship to PM 2.5 levels. We have established that link, but the pathway of its activity needs to be established, be it through endocrine disruption, be it through endothelial damage, or be it through stress that needs to be looked into. So I think we require studies which would evaluate the hypothalamic pituitary axis and relate it to PM 2.5, and that's a good question.
Thanks. Next question, what is the impact of noise pollution and how does it interact with air pollution?
So noise pollution has emerged as an important risk factor for hypertension. There are studies from the West which shows that people who are living closer to highways and closer to roads have a blood pressure which is 3 to 4 millimeters higher than other populations. Now, noise and air pollution should go together because vehicular emissions leads to air pollution. So there is that interlinkage. Teasing out between the two may be a little difficult, but can be done. We don't have that amount of granular data to say that it is one or the other.
Thank you. You mentioned during your presentation that in working with healthcare professionals Many of them weren't even aware of the association between air pollution and hypertension. I just wonder if you face any challenges or resistance from healthcare workers and healthcare providers in terms of implementing strategies to increase awareness about air pollution?
While the awareness may be poor, the healthcare providers are very enthusiastic about the relationship because it's a new knowledge for them. Many of them are not aware that, all of them are aware that air pollution can increase lung diseases, can increase asthma, can increase the risk of chronic obstructive lung disease, because you can make out that clear-cut connection, but the pathophysiologic mechanisms of its relationship to cardiovascular disease is poor. So once you create that awareness, they are happy to use that, and they're happy to look at and advise individuals, particularly people with recent myocardial infarction or heart failure. They should be advised on those days when the PM 2.5 levels are extremely high, not to venture out. Those simple advice can be given, and that's what we are trying to do with the healthcare providers, and also looking at ways and means of modifying their hospitals or their clinics in terms of making it more environment friendly is one of the things that we are discussing with them.
Great. Next question. Is there any interaction between NCDs and environmental pollution from crude oil, especially in oil-producing regions?
I mean, these are controlled environment, so unless you are, allowing these oil fumes to get into the environment, it's difficult to say. So I mean, to be very honest, I really don't know the answer for this.
Thanks. We have time for an additional 2 or 3 questions if one just came into the chat. Are there any studies looking at the blood pressure of industrial workers using noisy machinery?
There have been some studies in the past with 2 or 3 things. One is they looked at noise and looked at blood pressure to be higher in these industries which have a high degree of noise. So they have kind of looked at ways of controlling the noise. Second is at work sites, hypertension level is higher because of multiple reasons. Apart from noise itself, they have different shifts. People work at night shifts, and people who work more in the night shifts do tend to have a higher blood pressure. And also it is related to their eating habits, because many of the industrial sites provide food, at least in countries like India and many parts of Asia. Big industries provide canteens, and the canteen foods are generally kind of unhealthy. So we did a worksite intervention around 12 years back and showed that simple interventions at the level of the canteen, simple environmental interventions in promoting using staircases and walking, etc., can actually reduce many of the cardiovascular risk factors.
Thank you. How do we convince governments to regulate sources of ambient air pollution? Are there policy messages from the changes manifesting with the COVID-19 lockdown?
So first of all, in terms of air pollution, there is some amount of denial at least in some sectors of the government that air pollution is not such an important risk factor, because they point out to the fact that life expectancy has improved. If air pollution has increased, how will the life expectancy increase? So that's the argument so that is why we need studies like ours, which kind of shows that relationship. So if air pollution was not there, what could be the higher number of life expectancy that we would have? If our life expectancy in India currently is close to 68 years or so, without air pollution, it could go up to 70. I mean, that's the kind of analysis that we need to do. So the second is to create awareness. The third, of course, is to create a kind of movement amongst the people. As long as people don't ask that question to policymakers, it's not going to change, because we need to create that change amongst people. We need to make them advocates for change. And that is how it can be done.
Thank you. I guess that sort of answers the next question in the chat. Should the health community be more engaged with the climate treaty?
I mean, the answer is already there in the question. The answer is yes.
And the last question we have before we wrap up, are there any studies on peasant farmers, farming methods, including bush burning and NCDs? I think we sort of touched on this, but if you have any additional information.
I think sustainable agriculture is one of the areas which the UN is looking at, and there are multiple issues in farming. Apart from air pollution itself, crop burning itself, there are multiple other issues. We did a study looking at the role of pesticides in increasing the risk of diabetes, and there indeed is a relationship. In univariate analysis, we showed that relationship, but when we adjusted for age, it disappeared. The one issue why it could have disappeared, we didn't have the power to look at age interaction, but one reason why it could have disappeared because of age is because these insecticides are organic pollutants, and organic pollutants have a very high half-life. They take almost 10 years to decay. So it takes long years of exposure. So there are actually lots of issues like that in agriculture, and that's beyond the scope of today's discussion.
Thank you. And I think that concludes our Q&A portion for the webinar. Before we close, I would just like to say thank you, Dr. Prabhakaran, and thank you to the World Heart Federation for making this webinar possible. And thanks everyone for your active participation in today's webinar. I'll hand it over to Dr. Andrew Moran for any additional closing words.
Thank you, Lindsay. I know I really can't add to that. I'm just really grateful for Dr. Prabhakaran for your talk and for this great contribution to science. It has such huge potential to make a positive impact on health, and but it's also our responsibility to, as one of the questions suggested, to stand up for good public policy and put pressure on the governments and use these data to make changes. So thank you so much, and thank you to the World Heart Federation.
So thank you all.